Good morning again, class. So we now go to the second part of our discussion on the disorders of the thyroid gland. So in this session, we're going to talk about hypothyroidism and Hashimoto's thyroiditis. So hypothyroidism is a disorder with multiple causes in which the thyroid fails to secrete an adequate amount of thyroid hormone for our body's needs. So here you're seeking thyroid, no? The body is requiring him to produce more thyroid hormones, but he's too lazy, no, to produce thyroid hormones, so that's your hypothyroidism. So you can have several types, as we discussed in our several lectures in the past. We have primary and secondary. In primary, it's the thyroid gland that can produce the amount of hormones that the pituitary calls for. Therefore, you will have low levels of your T3 and your T4. In secondary hypothyroidism, it's the pituitary, or sometimes it's the hypothalamus if it's central. No? Central, you can't demonstrate anymore whether it's pituitary or hypothalamus. But if it's secondary, the thyroid gland is not stimulated enough by your pituitary because your pituitary is unable to secrete enough TSH to stimulate your thyroid hormone to produce to stimulate the pituitary is not able to secrete enough TSH to stimulate your thyroid gland to produce T3 and T4. So therefore, in pituitary, in secondary disease, it's your pituitary. If it's primary, it's the thyroid gland itself. So what are the symptoms of hypothyroidism? So we mentioned earlier that the metabolism slows down. Everything is slow. Everything is slow. So you will have low metabolism, and patients will feel tired and weak. They will have dry skin. They will feel cold because there's not much thermogenesis. There will be hair loss, difficulty concentrating, and poor memory because there's lack of excitability of the nervous system. Even the GI tract is slow. No, you will have constipation, and because the metabolism is slowed down, you will have weight gain, poor appetite. If there is, some patients will have some form of dyspnea, hoarse voice because of swelling in the airways, no? Menorrhagia, and decreased libido. Decreased libido is essentially mediated by your prolactin in this case. Remember that um, in patients with hypothyroidism, these patients can have markedly elevated TSH and TRH at the same time. And remember that your TRH not only affects your TSH but also your prolactin levels. And these patients might have markedly elevated prolactin levels, which in turn suppresses your GnRH again and FSH. Remember that from your pituitary. And the end result will be a decrease in libido. You can have paresthesias because these patients could have effects also on your nerves, impaired feeling. Not everything is slow. When it comes to signs, then you will have dry, coarse skin, cool peripheral extremities. You'll have puffy face, hands, and feet. Diffuse alopecia, so I'll show you some pictures later. Bradycardia because of decreased excitability of the heart. Peripheral edema, delayed TPRs, even carpal tunnel syndrome, and serous cavity effusion. Some patients will manifest with pericardial or even pleural effusion from very, very chronic hypothyroidism. And these patients can also have hypertension. Usually it's a diastolic kind. So diastolic hypertension for hypothyroid patient. On the other hand, in patients with hyperthyroidism, they usually have systolic hypertension. So these are the laboratory abnormalities. You can have dyslipidemia as well, even hyponatremia, and as I mentioned earlier, hyperprolactinemia as mediated by your TRH. So these are the manifestations. What you notice, no? In this patient, you will see they will have a sort of a blunt affect, no? Looks very drowsy. This patient is actually asleep already, no? They would have periorbital swelling, puffy face, And you will see them having dry hair, natural eyebrows are thin, peripheral edema, puffy dull face with dry skin. And this is your myxedema, swelling in the legs or in the anterior um, part of your legs. No? So this is a 56-year-old woman who had not received medical care for 30 years and she's still alive. No? Presented to the emergency department because of progressively worsening fatigue and confusion. And look at this, all the manifestation of hypothyroidism is exaggerated. So see very, very thin hair, you have alopecia, you have very puffy eyelids, no? Puffy face, and you have coarse, dry skin, and the nails markedly neglected, and the thinning of the outer eyebrows, no? Outer third of the eyebrows, brittle nails, you have non-peeling edema of the lower extremities, and after 1 year of treatment with levothyroxine, you see the hair grown back, the edema has subsided, and the patient looks happy. And the skin has returned to normal. There's no more edema. The nails are well taken care of. No? So see marked difference between your hypothyroid state and your corrected when normalize the thyroid function already. So what are the causes of hypothyroidism? It depends if it's primary, it's secondary. So that's why it's very important to be able to interpret your thyroid function test properly. So if it's primary, the most common in areas with sufficient iodine levels, it would be your autoimmune hypothyroidism or more commonly your Hashimoto's thyroiditis, sometimes trophic thyroiditis. It could be iatrogenic. Iatrogenic meaning you do something with your thyroid gland. Let's say a patient undergoes radioactive iodine ablation. No, usually patients with Graves' disease, one of the treatment modalities is radioactive iodine. So some patients will develop hypothyroidism after. Patients who undergo thyroidectomy for, let's say, a nodular goiter or suspected thyroid cancer, or even external irradiation not related to the thyroid, the external irradiation for neck, for of the neck, for lymphoma or cancer. That cause hypothyroidism. Others, your drugs, particularly those who have take iodine excess. So these are your contrast media, your CT scan, contrast, have very high levels of iodine. No? It can cause hypothyroidism as well, lithium, and of course your anti-thyroid drugs, and to some degree also your amiodarone, because your amiodarone contains high levels of iodine as well. Congenital hypothyroidism, we'll talk about that, and of course iodine deficiency or endemic goiter. That's one of the most common causes of your hypothyroidism in iodine deficient areas, and even infiltrative disorders. The others, nice to know but not common. So there's also such a thing as transient hypothyroidism, especially in cases thyroiditis or withdrawal of supraphysiologic thyroxine. So for example, your patient is receiving levothyroxine and the dose is already excessive, no? And then you withdraw it, you can have transient hypothyroidism. And again, even some patients will have transient hypothyroidism after treatment with RAI. So it depends. The response of patients with iodine 131 treatment or subtotal thyroidectomy could be transient, could be permanent permanent primary hyperthyroidism. For secondary hypothyroidism, meaning the cause is could be hypopituitarism, it could be from Sheehan's, trauma, even genetic or isolated, or even hypothalamic disease. So these are very conditions. The most common for this one would be your hypopituitarism, but in itself, it's still very much not very common. So earlier about congenital hypothyroidism. So in neonatal hypothyroidism, the most common cause will be thyroid gland dysgenesis. So during embryologic development, you are unable to develop a normal thyroid gland. Sometimes, in very rare instances, you can have inborn errors of thyroid hormone synthesis. So there's a genetic defect. Sometimes it's the TSH receptor that is defective, or there is a TSH receptor antibody mediated TSH receptor antibody that's blocking the TSH receptor. That can also congenital hypothyroidism. So this is an example of an infant at 6 months of age. The infant fed poorly in the neonatal period. As you can see, we notice a puffy face, a classic puffy face of thyroidism. We also have hirsutism in the forehead, um, and a large tongue, blunt affect. No? So she was constipated, had a large tongue, persistent nasal discharge, very lethargic, and no social smile and no head control at 6 months. So the mental um, growth and development is affected. And after 4 months of treatment, notice the decrease in the puffiness of the face. There's also decreased hirsutism of the forehead and a more alert appearance. No? And that's after replacement with the thyroid hormone. So this is a patient of mine, no? Initially seen at the emergency room because of vaginal bleeding referred by OBGYN when they noticed that the patient had retardation, features of retarded growth and development. So this is already a 30-year-old female that was like the height of about 3 feet. No, this is a patient with untreated congenital hypothyroidism, and when we did a thyroid scan, we found that the patient actually had thyroid disease, and that the thyroid gland is located in the underneath the tongue, so that's trilingual thyroid, no? Presented with megagia, stunted growth, and mental retardation. Fortunately now, congenital hypothyroidism can be detected in newborn screening. So we can detect hypothyroidism early on so that we can start replacing patients with thyroid hormone early on, no? When the patient, so that the will not be at risk or will have lower risk of developing mal and growth retardation. So usually we give high dose levothyroxine about 10 to 15 micrograms per kilo per day because of the increased requirement. Normally in adults we only report 1.6 microgram per kilo, but in the newborn it will be 10 to 15 micrograms per kilo per day. And early treatment with 4 or levothyroxine result in normal IQ levels, but only with very subtle neurodevelopmental abnormalities. So it's very important to replace this patient early on so that we can prevent this one. Okay. So now we move forward to your autoimmune hypothyroidism. No? The most common form will be your Hashimoto's thyroiditis. So in this scenario, you have autoantibodies that's attacking your king thyroid. So even when your thyroid gland is destroyed, this will result in hypothyroidism. So in Hashimoto's thyroiditis or goiteritis, you can have a goiter. In rarer cases, when it's very end stage already, when your thyroid gland has been consumed, no, you will have atrophic thyroiditis. In some patients, when it's just mild, some patients can, or it's just in the initial phase of your Hashimoto's thyroiditis, some patients have subclinical hypothyroidism, meaning the destruction of the thyroid gland is just beginning, or maybe even you can have mild hypothyroidism. So sometimes they can have subclinical hypothyroidism, no? High TSH and a normal FP4. But in most cases, these patients will present with overt hypothyroidism, usually TSH of more than 10. No? Usually, the goiter would appear large, regular, and firm in consistency. So how do we evaluate patients who have Hashimoto's thyroiditis? Usually when you check your thyroid function test, they would manifest either with overt or subclinical hypothyroidism, except of course if the patient is in the hyperthyroid phase of Hashimoto's thyroiditis. Actually, it's not hyperthyroid phase, it's thyrotoxic phase, meaning when the autoantibodies are destroying the thyroid gland, some of the preformed thyroid hormones are released, and the excessive release of the thyroid hormones during its destruction would result in symptoms of thyroid toxicosis. So this is wrong. This is thyroid toxic phase. No? And then eventually, once your thyroid hormones are consumed, then they would now be manifesting with overt hypothyroidism. And in this case, if you suspect Hashimoto's thyroiditis in a patient presenting with hypothyroidism, we request for anti-TPO or your thyroid peroxidase antibodies, and it's present in more than 90% patients with autoimmune hypothyroidism. Sometimes in patients who have multiple nodules that look suspiciously malignant, you can do an FNA biopsy because Hashimoto's thyroiditis can also be a risk for malignancy. I think particularly it's lymphoma that's increased in risk. You may confirm this with an FNA or a fine needle aspiration biopsy. We also request for thyroid ultrasound exactly to look for nodules, no, that could be potentially malignant, or but usually we find a heterogeneous thyroid enlargement. Let's say the ultrasound results of diffuse parenchymal disease. No? Differential diagnosis, it could be multinodular goiter or even thyroid carcinoma. So how do we diagnose and treat patients suspected to have Hashimoto's thyroiditis? Again, you measure first TSH, but if you're highly suspecting or very overt hypothyroidism, you can do both at the same time, TSH and FT4. If the TSH is elevated, you look at the T4. If it's normal, then interpretation will be subclinical hypothyroidism. So that's your mild hypothyroidism. You check your anti-TPO if it's if the TPO is positive and somatic or symptomatic, you can do low dose levothyroxine replacement. If the antibodies are negative, no symptoms, you just follow up. You just repeat the thyroid function test. If a patient has an elevated TSH and a low T4, no, that's your primary hypothyroidism, you check your antibodies, your anti-TPO is positive, then it is then autoimmune hypothyroidism. Then you can start T4 replacement. If your antibody is negative, rule out other causes of hypothyroidism. Let's say probably this is just iodine deficiency. No? So you just give patient iodine or I treat with iodine salt. So you don't need T4 replacement for that. If you have you have a elevated TSH and your T4 is low, and you have a setting where it could be a pituitary problem. Let's say the patient has other symptoms of other pituitary hormone deficiencies, like the patient has manifesting also with adrenal insufficiency or hypogonadism, or the patient has undergone pituitary surgery. No, you can suspect pituitary disease. If you don't suspect, then you don't need to work up the patient. That's your anymore. So if yes, you measure your T4, and if it's low, you rule out drug effects, secretory syndrome, and also evaluate the other anterior pituitary function. Evaluate the adrenal axis, the gonadal axis, so on and so forth. If the TSH is normal and the T4 is normal, then no further test. Your thyroid axis is intact. Sorry, if your TSH is, yeah, okay. Your thyroid axis is intact. So, what are the other causes of hypothyroidism? We have iatrogenic hypothyroidism, the most common cause after your autoimmune hypothyroidism, usually after radioactive iodine therapy, usually for Graves' disease or other causes of hyperthyroidism, such as toxic adenoma, or post-surgical. Let's say patient has multiple nodules or suspected to have thyroid cancer. The patient undergoes total thyroidectomy. Of course, you don't have any thyroid anymore. So you will have iatrogenic hypothyroidism or a post-procedural or post-surgical hypothyroidism. Iodine deficiency, No? In adults, it's endemic goiter. In children, it's cretinism. So ask where the patient lives and what kind of salt do they use. Do they live in the mountains? Do they use ordinary rock salt? No? This is an uncommon cause of adult hypothyroidism unless they are really in areas where there is iodine deficiency. Usually the relatives or the people in the community will also have some form of goiter. No? Chronic iodine excess, those who are taking amiodarone for, let's say, arrhythmias or chronic atrial fibrillation, or for other heart conditions, no? Because of the very high iodine content, it can cause hypothyroidism. Patients who have bipolar disorders, maintaining lithium, can also develop hypothyroidism. And of course, you have your central hypothyroidism as well. And in this case, as we discussed earlier, the TSH is inappropriately normal or low, and your FT4 is low. So you have an FT4 is low, you expect the TSH to be high, but if it's inappropriately normal, no, then you suspect central hyperthyroidism, especially if there's a setting for pituitary disease. Okay, so how do we treat patients with hypothyroidism? Very easy. You only have one drug to remember. It's your levothyroxine or your synthetic T4. No, it could be initiated as full or partial replacement depending on certain factors. If your patient is young, middle-aged, we give the patient the full calculated daily dose, which is 1.6 per kilogram body weight. So I usually ask this in the exam. I ask the patients to compute the calculated dose of the patient that the patient requires. If the patient has a serum TSH of less than 10, so probably the hypothyroidism is not is just mild, you can actually start at a lower daily dose, 25 to 75 micrograms. If the patient is other people who might require also lower doses are those that are elderly. Now, usually in the elderly, we start low and we go slow. Patients with known coronary artery disease, we also start low, no, either 12.5 to 25 with gradual increases. So in levothyroxine, the problem with levothyroxine, it has a lot of drug interactions, so that's why we need to take it on an empty stomach, usually 30 to 60 minutes before breakfast. So the known drug interactions of levothyroxine will be calcium and iron containing drugs or food not to be taken within 4 hours at least. So usually in patients who are on levothyroxine treatment, I ask them to take all vitamins, all supplements, either at lunch or dinner, so it will not interact. Other things that can interact with your levothyroxine would be coffee, Milo, milk containing food like sopas. No, I had a patient before who was eating sopas daily, and we could not reach his target TSH, and then we found that it was because of the food interaction, no, with the sopas and the levothyroxine. The dose could be lower if with residual thyroid function. Let's say the patient only had subtotal thyroidectomy, no? Or there's still underlying autonomous function after RAI for Graves' disease. No? If it's elderly or with heart disease, again, you start lower, usually less than 20% of dose, or I think they'll be safe at 25 to 75 micrograms per day. No? So usually levothyroxine is available in 25, 50, 100, and 150 microgram per tablet. So how do we monitor treatment? Remember in part 1, if it's hypothyroidism, it's TSH that we monitor. Now, usually we target lower half of normal dosage. Just mid-normal is fine. No, you check after 2 to 3 months after initiation of treatment. Usually I check at 3 months. No, there's really no urgency to check right away. You may monitor it every 6 months if only biochemically hypothyroid. No, but clinically the patient is not exhibiting any symptoms of hypothyroidism, therefore is clinically euthyroid. And once the TSH levels are stable, just check it once a year. Sometimes I just ask the patient to have their TSH levels checked. They text it to me, and then I advise them whether to increase or decrease their levothyroxine dose. They're very used to it already. The clinical effect of LT4 on TSH is slow to appear. So again, the earliest you can check TSH will be 6 weeks. That's the earliest you can get. Don't monitor every week. It will not change right away. No? And in most instances, there's no need to monitor FP4. I think the only scenario that I can think of right now that you need to monitor both TSH and FP4 when you're on levothyroxine replacement for hypothyroidism is only during pregnancy. No, only during pregnancy. Okay? Of course, there are exceptions, but those are um, just nice to know. Okay, so that's my last slide for this part. So for this session, I'd like you to read on your own about myxedema coma and also subclinical hypothyroidism and how to treat patients with subclinical hypothyroidism. So thank you for listening, and I'll see you in part 3.